Good day everyone, this is the group of Edorot, Gementiza, and Pedregosa. We are here to report about the prevention and management of oral problems of cancer therapy. This chapter is intended to highlight the importance of a coordinated team approach of the head and neck cancer care team, the general dental practitioner, and the patient in the prevention of oral problems by promoting consistent, high standards of oral care. Incidence of oral complication. Virtually all patients treated for head and neck tumors develop local problems. Approximately 40% of patients being treated for other cancers with chemotherapy develop mouth problems. Studies conducted in UK have shown that up to 90% of pediatric oncology patients may suffer from oral complications with implications both for longevity and quality of life during and after therapy. The prevention of oral complication is achieved in various levels or steps. The first step is the pre-treatment assessment. Many of the oral problems associated with cancer therapy can be prevented or minimized if intervention occurs before the onset of treatment with drugs or radiation. Thus, a protocol which includes pre-treatment assessment is recommended. Such objectives of pre-treatment assessment are A. Identification and elimination of 1. Asymptomatic oral infection, 2. Potential oral infection, 3. Sources and sites of chronic irritation, B. Pre-surgical assessment for prosthetic rehabilitation, and C. Initiation of regimens for prevention of radiation caries. How effective is the pre-treatment screening? A study conducted by Woods et al. Of 1989 showed that 72% of patients screened prior to bone marrow transplantation revealed positive findings of latent infection of oral cavity, irritating prosthesis, or restoration. When to do the pre-treatment assessment? Patients for radiotherapy, 3 weeks should be allowed between the time of dental intervention, especially extraction and start of the radiotherapy. Patients for chemotherapy, sufficient time between dental treatment and the patient's anticipated granulocyte nadir of less than 500 cubic millimeter period is required. The above protocol is not applicable in all the cases because of the acute onset of some of the hematologic neoplasms and the need for immediate therapy. Optimal timing for oral screening and intervention may not be feasible. The ideal components of a pre-treatment assessment are 1. Medical and dental history, 2. Laboratory data such as A-B status relative to herpes simplex type 1 virus, 3. Examination of head and neck, 4. Intraoral soft tissue examination, 5. Periodontal screening, 6. Dental evaluation, 7. Radiographs for the diagnosis of dental caries, periapical pathology. Pre-radiation dental treatment. Condition of dentition. Placing the patient in optimal dental health is important to prevent high-risk procedures in the post-irradiation period. All teeth with a questionable diagnosis should be removed. Teeth with advanced carious lesion, periapical infection, and significant periodontal disease should be carefully evaluated. The patient's periodontal status is probably the important consideration. In particular, molar teeth with furcation involvement in the radiation field should be removed. Mandibular teeth are commonly indicated for removal than maxillary teeth. Removal of asymptomatic, complete bony impacted teeth with no associated pathological features is not advised. Large tori or exostosis, as you can see in the photos, sharp or extremely irregular ridges, inflamed hypertrophic soft tissues in the radiation field in the edentulous and dentulous patients should be considered for removal because These areas can become traumatized and denuded, and the thin covering mucosa can atrophy, ulcerate, and expose the underlying bone. Radiation injury. Direct. Damages susceptible cells causing loss of tissue function, the salivary glands, mucosa, skin, and taste buds. For the indirect, results from decreased vascularity in subsequent tissue changes, hypoxic, hypocellular, hypovascular response. This includes changes in saliva, increase in caries rate, microbial shifts, and hard and soft tissue necrosis. Guidelines for pre-irradiation surgery. When teeth are removed, radical alveolectomy should be performed and primary closure obtained. Residual alveolar ridges should be smooth as possible. Sharp mylohyoid ridges and exostosis should be removed. A traumatic surgical technique with meticulous care of soft tissue flaps should be excised so as not to impair the healing process. Consideration should be given to the removal of groups of teeth in the radiation field, because it is easier to properly contour the alveolar bone and provide tension-free closure of soft tissue flaps. It has been suggested that 3 weeks or 21 days is required for healing that is sufficient enough to minimize the risk of osteoradionecrosis. Oral problems related to radiation therapy. The following are oral problems related to radiation therapy. 1. Mucositis. 2. Xerostomia. 3. Radiation caries. 4. Loss of taste. 5. Trismus. 6. Osteoradionecrosis. For mucositis, this results from mucosal atrophy as a result of a decreased cell renewal in the basal layer. Usually starts 2 to 3 weeks after the radiotherapy and is self-limiting, self-revolving 2 to 3 weeks after termination of treatment. The movable mucosa of the cheek, lips, soft palate, and ventral surface of the tongue are most often affected, as you can see in figure 1. Patients complain of burning sensation and their ability to tolerate hot and spicy foods decreases. Mucositis can be extremely uncomfortable and debilitating, causing decrease in oral intake. Prevention and management. Since the traumatized area easily ulcerate, elimination of sources of local irritation like removal of dentures, grinding of sharp edges of teeth, extraction of fractured teeth, and root stumps are done prior to start of radiotherapy. Children undergoing orthodontic therapy should have their orthodontic appliance removed and treatment discontinued until 1 year after completion of cancer therapy. Symptomatic relief can be achieved by the following drugs: aspirin, mucane wash, aluminum hydroxide plus magnesium hydroxide plus oxytazine will help to combat dysphagia when used prior to meals. This should not be used for children under 12 years of age. Rinses with xylocaine viscose 2%, diclone 0.5%, diclonine hydrochloride, cowpectate or milk of magnesia, and Benadryl diphenhydramine hydrochloride in equal parts are helpful to aid adequate oral intake. Newer drugs like Diflam, benzadamine hydrochloride, a non-steroidal rinse with anti-inflammatory, analgesic, and anesthetic properties have been suggested. Sucralfate is used in treatment of gastric ulcers, has been reported to be effective as a rinse by a number of investigators. Xerostomia and radiation caries. Xerostomia is one of the most consistent and bothersome side effects of radiotherapy. It is caused by the side effects of radiation on acinar cells, especially of serous glands, the parotid gland. Effects of xerostomia. The saliva turns thick, ropey, and acidic as serous function is diminished. Therefore, its effects as a cleaning, diluting, and mineralizing and buffering agent in the oral cavity is greatly diminished. Decreased output and increased viscosity of saliva can be an important factor in the use of removable prostheses. Prevention and management of xerostomia. 1. Amount of salivary tissue exposed to radiation to be minimized. Selective fields of radiation which maximize tumor exposure but minimize involvement of normal tissue are desirable. Meticulous treatment planning and beam arrangement designed to spare as much of the parotid and submandibular glands are done. 2. Stimulation of salivary gustatory and tactile ciliologogues. This can be achieved by local or systemic measures. Sucrose-free lemon drops, lemon slices, vitamin C tablets, or sugarless chewing gum may be used. Avoid cinnamon or mint-flavored mints or gum as they may irritate the mucosa. 3. Drug therapy. Salivary stimulants can cause unwanted side effects that are often more distressing than the xerostomia. The following have been used. Pilocarpine stimulates parotid function, but not submandibular or sublingual. The dosage would be 5 drops to 10 3 times daily. Anitoletrithion 1 to 2 tablets 3 times daily. Combination of pilocarpine and anitoletrithion. 4. Replacement of saliva as needed arises accomplished by the use of salivary substitutes. Most of these are based on either carbocymethylcellulose or mucin. The simplest technique in managing xerostomia is frequent moistening of mouth with sips of cold water, milk, tea, saline, or solutions containing sodium bicarbonate and sodium chloride soda. 5. Anti-caries regimen to protect dentition. Patients treated with radiation in fields involving the major salivary glands are at extreme risk for radiation caries. This is secondary to the reduced production and chemical change in the composition of saliva. Fluorides for dental use are provided in 3 forms: rinses, gels applied by brushing, and drops used in trays molded to fit over teeth. The use of tray-borne drops can be supplemented with rinses. Generally, the uses of rinses in the daytime and trays before sleep can be helpful. Loss of taste. It is a transient but bothersome sequelae of radiotherapy. This is due to the alteration of the function and architecture of the taste buds, usually reported during the second week and may continue up to 4 months after cessation of therapy. Total recovery may take up to 12 months. Some patients may be left with residual hypogeusia after radiotherapy. Zinc supplements are reported to be helpful in increasing taste acuity in such patients. Trismus. This occurs secondary to direct radiation to the temporomandibular joint and muscles of mastication, leading to fibrosis and scarring. The most decisive factor in the development of trismus is probably the inclusion of medial pterygoid muscle in the treatment portals. Mouth opening should be measured before and also frequently during the radiotherapy. Trismus leads to severe nutritional and hygiene problems. For the management, when symptoms start to occur, aggressive physiotherapy can minimize the limited range of motion. Patients at risk of developing trismus should be put on home exercise to maintain maximum mouth opening, use of tongue blades, rubber stops, or dynamic mouth openers is recommended. Osteoradionecrosis. Most significant complication of radiotherapy. Clinical manifestations may include pain, orocutaneous fistula, exposed necrotic bone, pathologic fracture, and suppuration. There are three types of osteoradionecrosis. Type 1 is the trauma-induced ORN, which occurs when radiation or surgical wounding are coupled closely together. The most common type is type 2, also trauma-induced ORN, which occurs years after radiation therapy. Type 3 or spontaneous ORN can occur anytime after radiotherapy, but commonly occurs 6 months to 2 years following radiotherapy without any obvious preceding surgical or traumatic event. 3 predisposing factors. A. Radiotherapy factors. Modes of therapy. Total dose exceeds 60 gray. Dose fraction with high number of fractions. Volume of mandible exposure and anatomic site of the tumor. B. Dental factors. Condition of the dentition. Motivation of the patient. Pre and post radiation extraction. And C. General factors. Patient is immunodeficient or malnourished. Management of osteoradionecrosis. The management of ORN still remains controversial, and there is no universally accepted treatment. In general, the following treatment modalities are practiced. 1. Control of infection with antibiotics. When there is acute exacerbation, since the necrotic bone is devoid of circulation, antibiotics do not penetrate it. 2. Analgesics. Narcotic and non-narcotic analgesics can be used. If pain is severe, alcohol nerve blocks or nerve avulsion is to be considered. 3. Surgical debridement is kept to a minimum possible. When small pieces of bone become loose, it can be removed easily. 4. Supportive treatment. Adequate hydration, high-calorie diet with vitamin supplements. 5. Oral hygiene measures. Chlorhexidine mouthwash or irrigation used frequently. 6. Sequestrectomy. When required, it is preferably done intraorally. This is because damage to skin and vascular structures can result as a result of radiation retards or prevents wound healing when performed extraorally. 7. Pathologic fractures. Even though not common, may occur from minor trauma. The fractures do not heal readily and pose great difficulty for successful treatment. Excision of necrotic ends of both fragments and replacement with large grafts has given promising results. Major soft tissue flap support also may have to be combined. 8. Resection. Bone resection is performed if there is persistent pain, infection, or pathologic fracture. If possible, it should be performed intraorally to avoid development of orocutaneous fistula and radiation compromised the extraoral soft tissue. 9. Hyperbaric oxygen therapy. This is useful adjuvant in the successful management of ORN and has revolutionized its treatment. It can be used alone or combined with surgery. Oral problems related to chemotherapy. Oral problems of cancer chemotherapy are the result of 1. Direct action of chemotherapeutic agent on the basal epithelium or primary stomatotoxicity. 2. Patient's inability to contain local minor oral disease due to myelosuppression secondary to stomatotoxicity. 3. Combination of both. Due to the disturbance in the activity of basal epithelium, epithelial renewal is diminished and atrophic changes are noticed. Mucosa becomes erythematous and patient is more sensitive with spicy and ulceration develops later on. The oral complications are dependent on various factors. They can be broadly grouped as A. the patient-related factors, and B, nature of chemotherapy. For A, the patient-related factors. 1. Type of tumor. Patients with hematologic neoplasm, leukemia, and lymphoma are at a greater risk of developing oral complications than patients with solid tumors, except tumors of head and neck. 2. Age of patient. Young patients develop oral soft tissue problems like mucositis more often than older patients. This is due to the increased mitotic activity of oral mucosal cells in the younger individuals rather than in older age group. 3. Pre-existing oral condition. Patients whose pre-treatment oral condition is poor are at a greater risk. Number 4. The oral cares during chemotherapy. The level of oral care during therapy markedly influences the development of oral complications and infections. Drugs such as B. Nature of chemotherapy. 1. Stomatotoxicity of the drug. 2. Schedule of administration. 3. Total dosage of drug. And 4. Concomitant therapy. Drugs such as methotrexate and adriamycin are markedly stomatotoxic and causes mucosal breakdown. The following oral problems are noted in patients receiving oral chemotherapy. 1. Mucositosis is 19%. 2. Infections, 33%. 3. Hemorrhage, 15%, and the others are 33%. Mucositis. Mucositis with ulceration usually occurs 5 to 8 days following the administration of chemotherapy and lasts for 7 to 14 days. Lesions heal spontaneously without scar formation. Management of mucositis is by use of topical medicaments similar to those used in the management of radiation-induced mucositis. Infections. There are 3 types. 1 is fungal infections, 2. Viral infections, and 3. Bacterial infections. Fungal infections. Candidiasis is the most common oral infection and appears as white crudiform or as erythematous macular lesions. It occurs on the palate, tongue, and corners of the mouth. Oral candidiasis, when it is poorly controlled, increases the risk of aspiration and the development of candidal esophagitis and orthogenia. Systemic candidiasis is the cause of death in as many as 1/3 of patients with immunosuppression. Hence, topical antifungal prophylaxis should be considered in all patients in whom granulocytopenia is anticipated. Viral infections. Herpes simplex type 1 is the most common oral viral infection in patients receiving chemotherapy or radiation therapy for head and neck tumors. The most common manifestation of HSV infection is oral ulceration, which clinically resembles other forms of mucositis. It can be the result of a primary infection with the virus or reactivation of latent virus in a previously exposed host, the latter being the most common. Lesions generally appear 18 days following the initiation of therapy. This time gap helps to differentiate HSV lesions from the lesions due to stomatotoxicity, which appears after 5 to 7 days, and those from secondary infection due to the myelosuppression, which occurs around 12 to 14 days. Viral culture is the most definitive way to diagnose HSV infection. For treatment and prophylaxis of HSV infection, systemic acyclovir is the drug of choice. Bacterial infections. Bacterial infections may be soft tissue, gingival, or odontogenic in origin. Odontogenic infection most often occurs as a result of advanced caries process when infection and degeneration of pulp occurs. Due to poor oral hygiene and xerostomia in cancer patients, there is subsequent increase in oral microorganisms. Infection due to anaerobic bacteria is more common. Extraction of the involved tooth under antibiotic cover is the treatment of choice. This is done after assessing the general condition of the patient. Measures for prevention of oral infection. Elimination of sources of mucosal irritation. The reduction in the oral microbial flora by various oral hygiene measures and oral rinses, mechanical or chemical means. Patients with removable prostheses should be instructed to remove them during the period of myelosuppression. Treatment of low-grade asymptomatic and oral infection prior to start of chemotherapy. Hemorrhage. Most often, bleeding that occurs during the periods of myelosuppression is of gingival origin. Slow oozing may be noted, especially in areas with pre-existing periodontal or gingival disease. Local treatment of gingival bleeding includes initial debridement, not disturbing the clots already formed, and topical application of thrombin under pressure. Hematoma formation often occurs in areas of trauma, especially the buccal mucosa, the alveolar mucosa, or the edentulous areas. Areas of submucosal hemorrhage form bluish blister, like areas which then form a yellowish-white tumor of fibrin. Summary of prevention and management of oral problems. Prior to cancer therapy, 1. A comprehension of oral assessment is undertaken. 2. Detailed oral hygiene instruction with reinforcement and elaboration of diet advice is provided in cooperation with the dietitian. 3. Oral hygiene practices are supplemented with the use of chlorhexidine mouthwash or dental gel if there is gingival disease diagnosed. Impressions of the mouth are taken for study casts to construct applicator trays where appropriate for obturator planning. 5. Carious teeth that can be restored are stabilized with appropriate restorations. 6. All sharp teeth and restorations are suitably adjusted and polished. 7. The patient is counseled about denture wear during therapy. 8. Wherever possible, teeth with a dubious prognosis are removed no less than 10 days prior to therapy. 9. Orthodontic treatment is discontinued. During cancer therapy, 1. Appropriate support from the dental hygienist. 2. High standard of oral hygiene. 3. Use of chlorhexidine mouthwash and dental gel. 4. Daily fluoride mouthwash to those patients receiving the radiotherapy. 5. When oral candida is detected, antifungal meds are used. 6. Every effort should be made to reduce the severity of mucositis. 7. Every effort is made to reduce the effect of xerostomia. 8. Removal of partial denture when there is an ulceration is advised. 9. When the mouth is too painful for cleaning, the tissues are swabbed with oral sponges. 10. Foods, drinks, and mouthwashes which irritate the oral mucosa should be avoided to maintain oral comfort. 12. Dental treatment is avoided wherever possible during therapy. Following cancer therapy, prevention and monitoring. 1. Growth and development should be closely monitored for children. 2. 3 months oral hygiene review for as long as the xerostomia continues. 3. Regular and appropriate oral health care monitoring is provided by the designated member of dental staff. 4. Strategies for dealing with the xerostomia continue. 5. A remineralizing solution such as the fluoride mouthwash continues to be used regularly with confirmation of compliance. 6. Chlorhexidine gel is applied with applicators. 7. In the event of chismus, jaw exercises are implemented. For the restorative dental care, 1. In the event of uncontrolled periodontal disease, vigorous treatment is initiated. This may involve identification of atypical pathogens. 2. Herpes labialis can be chronic problem. Topical acyclovir is effective. Restorations are kept simple, ensuring acceptable aesthetics and function. 4. Dental extractions, if essential, must be performed with appropriate precautions. 5. Denture should be avoided wherever possible. 6. Implant stabilization of prostheses and obturators may be feasible in some patients. Requirements for denture wearer. 1. Removable prostheses are left out at night. 2. Glandosane saliva substitutes should be used for edentate patient only. 3. Antifungals are used if a candidal infection is diagnosed. 4. Appliance wear is discontinued if mouth becomes painful. 5. Obturators are reviewed regularly. They may require frequent attention with adjustment or reaming. And that is all. Thank you all for listening.